talk about total knee arthroplasty in tuberculosis of the knee. Friends, just one or two slides about myth and facts about musculoskeletal tuberculosis. We know that the incidence of tuberculosis is about 127 per 100,000 population worldwide, but if you see, it is higher in developing or underdeveloped countries. For example, in African countries, the number is 220, and in South Asian countries like India, it is 211 per 100,000 population. And if you see the musculoskeletal tuberculosis, though it is about 1 to 2% of all tuberculosis cases, but it involves around 10 to 15% of extrapulmonary tuberculosis, and spine is the commonest site. That's why it has been presented first today, followed by hip in 25%, and knee is the least common site, that is 8%. That's why it is the last lecture today for total knee arthroplasty. Now, if you see in public hospital nowadays, we are seeing there is a reducing number of tuberculosis cases. We are not seeing so much of TB hip, TB spine cases, what you used to see when I was a lecturer or when I was an associate professor. Whether the number is reducing, I don't know. But definitely the resistant strain is increasing. We are getting more and more resistant tuberculosis cases and more in immunocompromised patients. So immunocompromised means not only the poor patient, it is in the higher strata of the society, high socioeconomic status patients. Those who have got immunocompromised status, they are also developing tuberculosis. And we are seeing many atypical mycobacteria which we discussed in the earlier part today, and I will just present one case of atypical mycobacteria in the last part of my lecture. And knee tuberculosis is often misdiagnosed. Often the rheumatoids, osteoarthritic patients when you operate, or sometimes in sarcose joint also there is a possibility of tuberculosis that we need to have a high index of suspicion and you have to diagnose it. Though the clinical manifestation is classically pain and swelling, any knee joint affection that may present with, but sinus tract formation should raise a doubt about tuberculosis even if the patient is not operated before. And there is a possibility of mass formation around the knee joint. Even if it not inside the knee, around the knee, if there is a mass, then think of tuberculosis, and it, in addition to any of the other differential diagnoses. And very few patients, almost 20% patient develop fever. So fever and weight loss and loss of appetite, these are not the usual manifestation of extra-articular or extra pulmonary tuberculosis like bone and joint tuberculosis. Lab investigation, usually you send ESR and CRP. Remember, ESR is a preoperative, it assesses preoperative disease activity, whereas CRP assesses the response to antitubercular treatment during postoperative period. So these are the two acute phase reactants, the markers which can be used preoperatively or postoperatively. And X-rays, what you describe is the classical Femister triad, that is juxta-articular osteoporosis and peripheral osseous defect. If you find like this, then probably it goes more towards tuberculosis with a narrowing of the joint space. Now, MRI has almost given us the diagnosis of tuberculosis. Usually no cases are missed preoperatively if you do an MRI, and if the MRI shows there is a synovial proliferation which is hypointension T2 images and periarticular changes, almost the radiologist give you a diagnosis that there is a osteoarticular infective pathology, most likely due to tuberculosis. Of course, the biopsy will confirm that there is a granuloma. You can send it for gene export and culture, and we have discussed it enough during earlier part today. So basically, there are four groups of patients when you are thinking of doing a joint replacement or in tuberculosis. The first group is a accidental detection during the surgery. And during the surgery, suppose a rheumatoid patient or osteoarthritis patient whom you have taken it for, either for a knee replacement surgery or any other surgery, and if you find there is a, certain amount of caseous tissues or tissues like this, and you sent it for frozen section, so it may come out to be tuberculosis. So in this type of cases, do a very meticulous debridement of this thing, and use streptomycin in the cement, and amount of streptomycin for a primary fixation of the components is 1 gram per 40 gram packet of the cement. I use stimulant very often and add 500 milligram of streptomycin to 10 gram, stimulant, and put it in around the soft tissues, and you can put it inside the intramedullary canal if you are using intramedullary jigs. And post-operatively, then you put these patients on treatment for about 1.5 years, depending on the treatment, like 4-drug regimen for about say 2 months, followed by your 3-drug or 2-drug regimen. And post-operatively, always retrieve the synovial tissue and send it for biopsy, so that your tuberculosis is proved. And you can send it also for drug sensitivity and see if there is any resistant tuberculosis there. Normally, I tend to put these patients in addition to the 4-drug regimen, quinolones like ciprofloxacin, which is an anti-tubercular drug, as well as its anti-biofilm agent, which will protect in future recurrence of tuberculosis. I put them on 5-drug regimen. The second group is a early active tuberculosis of the knee, where you can do a 1-stage total knee arthroplasty, but remember, there should not be any sinuses, or there should not be any frank pus pockets anywhere, and your inflammatory markers should be normal before the surgery. If these 3 criteria are met, you can put these patients on tubercular treatment. Literature shows that they have done a knee replacement surgery after putting 3 weeks of the treatment, but like Dr. Bhosle said, that we prefer to give at least 3 months of treatment before doing surgery, because usually there is periarticular osteopenia or osteoporosis, and your fixation of the components will be poor if there is osteoporosis or osteopenia. So at least if you give 6 weeks, 3 months of antitubercular treatment, the bone quality becomes better, and hence fixation of the components becomes better, and hence you should have a good long-term outcome. So again, you require a very meticulous debridement, take out all the granulations and the synovium, etc. Again, as I told you, add streptomycin 1 gram per 40 gram packet of the cement, and stimulant 500 milligram per 10 grams. And post-operatively, you can give these patients, put this patient on treatment for about 1.5 years. And post-operatively, of course, you send the synovial tissue for diagnosis, as well as gene export and culture sensitivity tests. So this is one of our patients which has undergone this 3.5 years follow-up of this patient after giving anti-tubercular treatment. The third group is a late active stage, where you require basically 2-stage reconstruction. Here either there is a presence of a sinus, or there are frank pus pockets which are around the knee, and or in spite of giving anti-tubercular treatment, your inflammatory markers remains high, both ESR and CRP remains high. So here you require a 2-stage reconstruction. So first stage you put a cement spacer. So after giving about 3 weeks or 3 months of anti-tubercular treatment, do a debridement, put a cement spacer, and after doing a meticulous debridement, then you put a cement spacer, and the second stage after about 3 to 6 months, then you do a second stage reconstruction using the components, and post-operatively again you continue the anti-tubercular treatment. And this is one of the patients where in the first stage you put a cement spacer there. I'll take little time to tell you how to prepare a cement spacer in this kind of patients, and this is post-operative 6 years follow-up of this patient. So since these are the primary native knees, here the cement spacer should be what I tell about a cruciate retaining type of spacer. This is a biomed kind of templates which are available, where you prepare cement spacer like this and put it like this. The advantage is that you do not open the medullary canal, hence you prevent the spread of infection inside the intramedullary canal. So you just take the bone cuts, the distal femoral cut, AP cuts, and the chamfer cuts using an extramedullary jig rather than using an intramedullary jig. So with the extramedullary jig, you prepare this on the femoral side, and on the tibial side anyway you use the extramedullary jig and just take the proximal tibial cut. Do not take any other cut on the tibia, and do not open the intramedullary canal. So you can put this this kind of spacer and put stimulant in the soft tissues. So this type of templates are expensive, but what you tend to reuse this. So once you open it, then you can ETO it and reuse it, and you need a gun and a syringe to prepare this cement spacer. And stability is a issue with this kind of spacer, because there is no post there, and hence there is a possibility of dislocation. So we prefer to use is native infected knees, either a tuberculosis or in a pyogenic infection. whenever you are using a cement spacer, you can use more streptomycin until from 4 to 8 grams of streptomycin in 40 gram packet of the cement. Well, that is 20% volume by volume, because in that the elution of the antibiotics in the cement becomes greater to the surrounding tissues, and you can add extra antibiotic like vancomycin, because if there is a sinus, there is a possibility of secondary infection through the sinus tract, and hence vancomycin as well. And add the powder gradually while you are mixing the cement, rather than mixing all the powders to the cement powder beforehand. You can just put the cement and then put the liquid, and when you are mixing the cement, gradually add little powder and start mixing this cement. And stimulant you can use in the soft tissues. And as I told you, I prefer to add anti-biofilm antibiotic. Rifampicin anyway we give as anti-tubercular antibiotic for gram positives, and ciprofloxacin I add for gram negatives as an anti-biofilm antibiotic during post-operative period. The last group is an old healed disease. The primary total knee arthroplasty, it's an old healed disease when there's a past history of tuberculosis where the patient has already been treated. So you have to just look for is that the normal inflammatory biomarkers. In those kind of patient, again you add streptomycin and stimulant, and post-operatively these patients has to be put on at least 2 drugs, INH and rifampicin, for about 3 to 6 months. Previously you used to tell 3 months, but nowadays people are telling give little prolonged period since about 6 months, so that it prevents any recrudescence or recurrence of the tuberculosis. And is there any suspicious tissue around inside the joint, then you can send a tissue for histopathological examination, so that post-operatively you can continue the anti-tubercular treatment for an extended period. The complications are usually reactivation tuberculosis if you do not treat them inadequately, or if there is a resistant tuberculosis. So in spite of giving anti-tubercular treatment, if there is a reactivation, then it requires a look for any resistant tuberculosis, or there is a possibility of periprosthetic loosening. And periprosthetic fracture is common because the bones are of poor quality. That is why we prefer to give antitubercular treatment for about 3 months, so that bone quality improves and it prevents a periprosthetic fracture. And there is a possibility of tubercular infection after knee replacement surgery also. Various reports has been there that tuberculosis is happening after knee replacement surgery. If you see the literature, this is literature just published last month, April 2024 literature, which shows a total knee arthroplasty after tuberculosis of the knee. The maximum follow-up is 2 to 11 years, so it is a comparatively new kid on the block compared to hip replacement, which has been done for many years. So there are only 6 papers which show very few cases they have done, and the follow-up shows a good outcome, at least excellent or a very good outcome after the surgery. Now, before I conclude, one slide about atypical mycobacteria. Again, I stress upon what has been told in the morning. This is a patient who was undergone a arthroscopy, a meniscus repair, and then got infected, debridement done, then didn't get recurrence of the infection, second debridement done, again recurrence of the infection, presented to me with a discharging sinus. And in this kind of patient, the X-ray was like this, and we did a debridement and put a cement spacer there. So smear shows AFB positive, whereas gene expert shows negative. So if you find a situation like this, as you have seen many cases which Dr. Agashe presented in various meetings, so immediately it struck to mind it could be atypical mycobacteria. And since there is a previous intervention arthroscopy, now this patient, this tissue is, we have sent the tissue for bacterial and atypical mycobacteria NTM culture, and after culture we will give appropriate antibiotics. Now we have just put a cement spacer and a stimulant there. So take home message, dear friends, diagnosis of tuberculosis of knee is multimodal. MRI is a reliable tool. Nowadays, you should do MRI in each and every case. Anti-tubercular chemotherapy is essential during perioperative period. One stage total knee arthroplasty is possible in early tuberculosis, where you continue anti-tubercular treatment for 1.5 years after a meticulous debridement and putting the joint. And 2-stage reconstruction has a lower risk of recurrence whenever there is a presence of a sinus or presence of a purulent pocket, and when the inflammatory markers are high. And always add streptomycin to the cement. I thank you for a patient hearing.